our Take Action series for the County Health Rankings and Roadmaps program, Assess Needs and Resources. My name is Kate Conkle, and I am a community coach with the County Health Roadmaps project. My colleague, Karen Odegaard, is also here, and she will be helping to answer your questions along the way. We are pleased to be joined by Amy Newelt, Prevention Specialist with the Public Health Institute in Oakland, California, and Dr. Dalit Ball, District Health Officer in Kauai, Hawaii. The County Health Rankings and Roadmaps program is the result of the contributions of many partners, including the Robert Wood Johnson Foundation, our colleagues here at the University of Wisconsin Population Health Institute, and the various partners who help us compile the rankings data to get the message out about rankings and roadmaps. We want to take a moment to get you oriented to the technology we're using today. The GoToWebinar attendee interface is made up of two parts. On the left, you can see the viewer window on which you'll see my screen throughout the presentation. On the right, you can see the control panel, which is where you can interact with us. Because of the number of people we have on today's webinar, we will be taking questions via the control panel. Feel free to enter your questions in the control panel at any time throughout the webinar, and we will answer them towards the end. If we don't get to your question during the webinar, we will follow up with an email. When you registered for this webinar, we asked you to let us know what's going well with assessing needs and resources, and here were some of the themes that came out of your responses. One was that you've successfully collected data, both secondary and primary. And another was that you've used that data to select your priorities and set your direction. We also asked what's been a challenge with this particular step, and these were some of those key themes. One was coordinating and aligning multiple assessments. I think that is definitely a challenge. Engaging partners and the community in your assessment, finding local data on needs and resources, and finally finding resources to actually carry out your assessment. So we've designed today's webinar with this input in mind. Here's a quick outline of today's webinar. We're going to start with a brief overview of County Health Rankings and Roadmaps just to get you acquainted with the site. We'll then talk with Amy about chna.org and how it can help hospitals and organizations seeking to better understand the needs and assets of their communities. Dr. Ball will then show us how Kauai collected and used primary data in their community health assessment. And then finally, we'll take some time to answer your questions before we wrap up. Again, if you have a question or comment at any time, please be sure to write us in the question box. By the end of this webinar, we are hoping you will know where to find tools to help assess your community's needs and resources in the Roadmaps to Health Action Center and at chna.org. Understand how one community used primary data in their assessment, and understand the role of primary data collection in your assessment. Before we get started, let's take a moment to see where you're at with assessing your community's needs and resources. So we're going to put a poll up if you can all take a moment to let us know how things are going. Give you a couple more seconds to fill in your answer. All right. Thank you so much for all of you who answered the poll question. It looks like there's we're fairly split. There's lots of you who are just getting started, so we're happy that you're joining us today, and hopefully we'll get some great information on how to take this first important step. Lots of you are collecting your data, and hopefully this will give you some insight into some other ways to collect information besides that secondary data many of us look to get started. And it looks like a good number of you have collected and interpreted your data and are ready to start to move forward, which is really exciting. This might give you, we often have to return to our assessment phase throughout the process, so this might give you some good insight should you need to come back and re-look at some information or collect some additional information in the next phases of your action cycle. So thank you so much for sharing that information. So now let's start looking at our County Health Rankings and Roadmaps site. So based on the information you provided when you register, most of you are familiar with the County Health Rankings, which ranks the health of nearly every county in the nation. And the rankings illustrate what we know when it comes to what's making people sick or healthy. This model really underpins the County Health Rankings. Starting at the bottom, we believe that effective local, state, and federal policies and programs can improve a variety of factors that, in turn, shape the health of communities. Many health factors shape our community's health outcomes. We specifically look at health behaviors, clinical care, social and economic factors, and the physical environment. We measure two types of health outcomes to show how healthy each county is: how long people live and how healthy people feel. When communities assess their needs and resources, they often start at the top of this model, looking at how long people live and how healthy people feel, and then digging deeper to understand the health factors that influence those health outcomes. Understanding your community's strengths and challenges will help you to take action through policies and programs that build on your strengths and address your challenges to improve health. This is where County Health Roadmaps comes in. Roadmaps show us what we can do to create healthier places to live, learn, work, and play. Roadmaps helps communities take action. So this is the countyhealthrankings.org homepage. And from here you can get to your County Health Rankings data, your county snapshot, and you can get to the County Health Roadmap section of the website. From here, you can find a variety of tools and guidance to assist communities in the Action Center, as well as What Works for Health, which is a database of nearly 200 evidence-informed policies and programs. Community coaches are also available to consult with you about how to best move action forward in your community. Karen and I are two of those community coaches, along with our colleague, Jan O'Neill. In the Action Center, you can click on any step in the Take Action cycle to find guidance and tools for the various activities that make up that step. Our Assess Needs and Resources guide breaks this down into 10 key activities so you can find guidance and suggested tools for exactly where you are in the process. So for those of you in the middle, you can find tools if you've already started this and are looking for the next steps. And for those of you just getting started, you can start at the top and work your way through. So now we're going to turn things over to our guests. Our Assess Needs and Resources guide linked to chna.org, the tool that Amy Newell will be telling us about. But first, I'm going to tell you a little bit about Amy. So Amy is a prevention specialist with the Public Health Institute in Oakland, California. She currently serves on the work group for chna.org, a free web-based platform designed to assist critical access hospitals, nonprofit organizations, state and local health departments, and other organizations conduct robust community health needs assessments and design effective implementation strategies. She also leads the design and implementation of a customized data, communications, and content management system for 42 California counties participating in the Community Transformation Grant Award awarded to the Public Health Institute. Ms. Newell holds a BA in Community Health from Brown University and an MPH degree in Population and Family Health from Columbia. So we are going to turn things over to Amy to give us a brief introduction to chna.org.
Hi, everyone. Can you hear me all right?
Yep, we can hear you.
Great. Thank you. Well, thank you everyone for joining today, and thank you to Kate for hosting this webinar. For the next 10 minutes, I'm going to provide a pretty high-level overview of the chna.org tool and how we used it to support the community health needs assessment process in Kauai that Dr. Ball will be discussing in today's webinar. I know we will have a more in-depth webinar on this tool in about 2 weeks, but for now I'll just give a really kind of high-level overview of the different features of the site and how we used it for the Kauai community health needs assessment process. So first, let me provide some background on the CHNA tool. It is a free web-based platform designed to assist hospitals and other organizations seeking to better understand the needs and assets in their communities, and in order to collaborate to make measurable improvements in community health and well-being. It's a powerful data tool that houses a common set of secondary data sources in order to assess the needs of any county in the U.S. So for the Kauai Community Health Needs Assessment process, we use this tool to quickly visualize and analyze a host of secondary data sources, saving considerable time and resources for us to focus on local primary data collection that Dr. Ball will speak about. The secondary data gathered from the CHNA tool were presented during the initial Kauai CHNA leadership team meeting and are being embedded in the final report that the team in Kauai is currently working on. So you can see on my screen the home page for the site for CHNA.org, but it's actually one piece of a larger online resource called the Community Commons, and I'm going to show the home page for the Community Commons right now, which is at www.communitycommons.org. And if you haven't heard of the Community Commons, I strongly recommend that in addition to checking out the CHNA toolkit, you also create a free registration for the Community Commons. The Community Commons is an interactive mapping, networking, and peer learning utility for the Healthy Communities movement. And even if you're already registered on the Commons, I recommend that you go back and check out the site since it recently went through a bunch of really fantastic upgrades to the mapping environment and the group collaboration spaces. So going back to the specific CHNA tool on the Community Commons, this was created by a broad work group representing various national organizations, including the CDC, NACCHO, ASTO, the University of Wisconsin Population Health Institute, United Way, and us here at the Public Health Institute, among others. A main focus of the work group was to determine a common set of indicators that any U.S. county would want to look at to really focus their assessment process. IP3, which is the Institute for People, Place, and Possibility, is the technical team that built the tool and provide technical support behind the site. And the system is actually available at no cost due to the generosity of Kaiser Permanente, which built a similar system for their community benefit programs within their hospital network, and then donated the programming language to make this publicly available tool that I'll show you today. So when you first come to the site, I strongly recommend that you check out this introductory video on the left, and that'll give you an overview of the different tools on the site. And there are really three main tools. The first being a vulnerable population footprint, a number of community health needs assessment report tools down here, and a gallery of maps that you can create for different health indicators. So the first tool that I'll show you is the Vulnerable Population Footprint tool. And what you can do is type in where you'd like to get started. I'm going to go over to Kauai. And the map automatically displays the hospitals in the region, as you can see in this legend on the right-hand section of the screen. And if I click on Label, we can actually see the names of the hospitals. And this hospital here, Wilcox Memorial Hospital in Lihue, is part of the Collaborative Community Health Needs Assessment with the Kauai District Health Office that Dr. Ball is going to describe in a moment. So right now we're looking at a map of Kauai and of the different hospitals on the island. But what we can actually do is look at two important social determinants of health by census tract. So one we can look at is for each census tract the percentage of the population that's living below the poverty level, and that will be shown in orange. And then also we can look at the percentage of the adult population by census tract without a high school diploma, which will display in purple. The census tracts that exceed both of these the standards that we set dynamically are going to be highlighted in red. So what we can do is go down to the tab for footprint definition, and you'll see that the thresholds we have right now are 30% for poverty and 25% for high school non-completion. But what we can actually do is lower those thresholds down to 10%, and you'll see that the map dynamically changes to highlight which particular census tracts meet these new definitions. So, going back to our layers, you can see that these red census tracts that are highlighted meet both of these standards that we've set for over 10% of the population living below poverty and over 10% of the adult population without a high school diploma. You can also click on a particular census tract to get more the underlying data for that particular region. Also going to the footprint report, you can actually either draw a custom area or just use the current map area and generate a report that has a summary for those red census tracts, including a breakdown by age, gender, and race ethnicity. So this tool really helped as a useful starting point for us to think geographically about where to target interventions and thinking about upstream social determinants and needs and resources for the assessment in Kauai. So I'm going to go back to the main page and now scroll down to the Community Health Needs Assessment Report tool. And you'll see that there are 4 different options to choose a different type of report, including one that focuses on a small number of core health indicators, a full report with all the indicators available in the tool, one that focuses on comparing the indicators for your county with the Healthy People 2020 leading health indicators, and several other community health needs assessment reports that aligned with the assessment process that major hospital systems, including Kaiser Permanente and the Catholic Healthcare Association, use for their own community benefit needs assessments. So right now I'm going to focus on the full indicators report, and note here you could click on the indicator data list to see the full number of indicators available in the system. For our example here, I'm going to click on Hawaii and the county of Kauai, and note that you can actually pick multiple counties if you wanted to get data for a region of multiple counties. But for now, I'm going to X this out and just focus on Kauai and click on View Report. So when I click on View Report, I have now almost 100 different indicators for the county of Kauai that have been processed incredibly quickly. And this saves a large amount of time sifting through various secondary data sources like the U.S. Census and BRFSS. So this report can actually be downloaded as a PDF or as a Word document. And what's nice about having it as a Word document is you can actually add any supplementary text that you might need. Now, thinking back to the county health rankings model for population health that Kate just displayed earlier, you'll see that following these basic demographic indicators in this first tab, the indicators within this report tool align with the county health rankings model. So we have the social and economic factors, indicators for the physical environment, clinical care, health behaviors, and health outcomes. So this really lines well with the county health rankings model. And many of the data indicators that you can find within the county health rankings site in the particular measures are also available within the system. So for now, let's click on social and economic factors, and we'll focus on an upstream determinant for unemployment. So for each of the indicators within the system, you'll see that there's written context about the significance of this particular indicator and why it's important and how it impacts health. And you'll also see how Kauai compares to several benchmarks. So for in this table, you can see that the unemployment rate is slightly over 6% as of the last time these data were updated in January of this year. We can see the date down below, January of 2013. The 6 is highlighted in red, which is similar to a stoplight to signify that Kauai is doing worse for this particular indicator than one of the regional benchmarks, which in this case is the Hawaii statewide benchmark of unemployment rate of only 5%. And you can also see that this comparison is highlighted in a dashboard to the right, which compares Kauai with the state and U.S. levels of unemployment. The dial here is red, but it would be green if for this particular indicator Kauai was doing better than one of these benchmarks. So it really provides a quick visual comparison. Below there's also a map that you can expand if you wanted to compare how Kauai is doing with respect to unemployment relative to other surrounding counties. And where it says download data, you can actually download the data into an Excel file for other analyses. For each indicator within the system, if you scroll to the bottom, you'll see all the data sources and methodology. And these are, all of this information is included in the PDF or Word document that you can download for this report. So we use these quick visual indicators for these different data with the Kauai Community Health Needs Assessment leadership team during the first meeting back in January to really highlight where Kauai is doing better relative to the state as a whole. For example, with respect to infant mortality and the number of grocery stores per 100,000 population. But also during the meeting, we used this tool to really hone in on where Kauai can improve relative to the state as a whole. So for example, suicide rates and rates of binge drinking are higher in Kauai than they are for the state as a whole. So having these data visuals live and interactive during these leadership team meetings was really useful to generate discussion and to begin to target priority areas. And many of these dashboards, maps, and other visuals are being incorporated into the final CHNA written report to display the assessment in terms of health needs and resources. So going back to the main page, I'm just going to show you one final tool. And that's at the bottom. You'll see that there's a map gallery. And this map gallery is, again, a useful way to visualize and analyze the health needs and resources in your community. You'll see that all the data available within the CHNA report tool that I just showed you are also available for creating customized and interactive GIS maps. And again, the data are organized in alignment with the County Health Rankings model for population health. So one map that we looked at to assess both needs and resources was a map of the schools on the island by the percentage of students available for free and reduced price lunch. And the school superintendent for the island is part of the Kauai leadership team. So looking at schools and this correlate of low-income students is actually a really helpful way to target for this assessment where community building health interventions might take place. So for this example from the map gallery, I clicked on selected population density as the background. And then going down to tools, you can see that we can add more data. You can use a keyword, but for this situation, I know that students eligible for free and reduced price lunch is part of the social and economic factors. So adding that data, you see that they appear on this map, and over on the right we have the legends. And you can also select to get more information for each indicator. Also, to help see this visually, because I know some of these schools are masked a little bit with the data layer behind it, you can actually turn it into a satellite map or change the transparency. So there's a lot of things that you can do to kind of visually support your case for the type of map that you're making, the type of data that you're displaying. And all of these maps can be exported into a PDF or a picture file for you to save and include into a report. So to do an analysis using this tool, I'll just give you one example for what we did. You can click on the particular data layer that you're interested in. So let's say we want to look at an analysis of the schools on the island. And going down to Tools, you can click on Query Data. And we're looking at the indicator for schools. And I'm going to select percent of students eligible for free or reduced price lunches. And I want to find all of the schools where there's over 60% of students that are eligible, and also see a table for those data. So when you click on Query, you'll see that the 3 particular schools and the underlying data appear in this table that you can download into an Excel file, and they also appear here on the map. So those are the 3 main tools I wanted to quickly give you an overview for on the CHNA site. The IP3 team behind the site is always open to hearing more feedback, and there is a feedback button for you to let them know any enhancements that you'd be interested in for this site. On the left, you'll see there's a section for FAQs. There's also some more tutorial videos, and there's a link for additional resources. There's really just a wealth of helpful resources here for the community health needs assessment process. And in fact, at the bottom, in terms of setting priorities, you can see a link for the What Works for Health database from our friends at the County Health Rankings and Roadmaps program. So that's the end of my demonstration. Hopefully that gave you a good sense of how we use the site to assess some of the needs and resources in Kauai. And Dr. Ball is now going to focus on the local primary data collection process.
Great. Thank you so much, Amy. That was a really good brief introduction to chna.org. And as Amy said, in 2 weeks on May 28th, we will actually be doing a more in-depth webinar limited to a smaller group of participants that will delve a little bit deeper into some of those tools available on chna.org as well as on the County Health Roadmaps Action Center site. So think about joining us for that if you're interested in seeing more about how to use those resources. But next we are going to turn to looking at one of our local communities that has done a really nice job with assessment. We are welcoming Dr. Ball, and he's got an extensive, sorry, we're getting a little feedback here. He's got an extensive resume and bio, but I'm going to give you a brief introduction. Dr. Dilip G. Ball began working in Hawaii State Health Department of Health in September 2005 as the District Health Officer for the island of Kauai and as a special advisor to the Director of Department on Cancer, Chronic Disease, Tobacco, and Nutrition. He is a clinical professor at both the University of Hawaii Cancer Center and the Department of Family and Community Medicine of the College of Medicine at the University of Hawaii. Dr. Ball began with the state of California, was with the state of California for over 2 decades prior to that, where he served as the chief of the Cancer Control Branch within the Department of Health Services. And prior to that, he was in Tucson, Arizona for 10 years, where he was the director of the Pima County Health Department and on the full-time faculty at the University of Arizona College of Medicine. He was born and educated mainly in New Delhi, India, and he's very active with the American Cancer Society at the local, state, and national levels. And in 2000 to 2001, he was the national president of the American Cancer Society. So we're really lucky to have such an accomplished presenter with us today and look forward to hearing about the assessment that was done in his community. So welcome, Dr. Ball.
Thank you very much, and aloha all.
So we wanted to start just by getting some more information about your community. And can you tell us a little bit about the island of Kauai?
Well, as you see from what you have up on your screens, we're the smallest of the major Hawaiian islands. That's the islands of Hawaii, Oahu, Maui, and Kauai. We're the westernmost outpost of the United States. We're mainly rural. And again, in terms of the economy, it's moved from being, it used to be agricultural mainly in the old days. It, as you know from the fact that even the name of the company is California and Hawaii, CNH Sugar, it used to be a very heavy producer of sugar cane and manufacture of sugar. Unfortunately, it can be done cheaper elsewhere. So our main economy now is tourism and government, especially the military, because given the state of the world, we have a large military presence in Hawaii. That briefly is where we are. And again, in terms of size, I have about 70,000 people on this island, so I have about 5% of Hawaii's population. And any given day, I have another 20 to 30,000 visitors. So that is an additional public health burden on occasion.
Okay, great, thank you. So let's talk a little bit about what Kauai is doing in terms of health assessment.
Basically, you'll see from my presentation that it looks like, again, first of all, I've really got to thank Kate and the entire group doing the community health rankings and roadmaps. I think it was very sweet of them to invite me. And to some extent, I hate to sort of say this, but their particular website is the one that is very convenient for an old guy like myself. I go there all the time if I need to find something out. Amy, God bless her, is an expert of the chma.org. It's a little bit more complicated for those who are internet challenged like myself, and she's patiently tried to teach me some of this stuff. Well, where we are in CHMA is very simple. Amy has told you how she has been of inordinate help to us on mining our secondary data sets. And what Kate is asking me to speak about is mainly where we've done de novo primary data sets, and I believe that's going to be the focus of my presentation. Those of you who don't know about the Community Health Needs Assessment, it's a requirement of the Affordable Care Act, and it basically requires every hospital, every nonprofit hospital that has its 501c3 status to do a community health needs assessment in the immediate environs of their hospital, their catchment area. And there are some specific requirements. It requires them to do this every 3 years. They have to file the enforcement of this is jointly with the Department of Health and Human Services and IRS. And they are also required, I emphasize required, to consult leaders, representatives, or members of their target populations and consult with health departments. And that has happened patchily across the United States, as we're going to go into shortly.
All right, great, thank you. And thanks for setting the stage on what is, even though it is required, what is an open door for partnership between public health and other community partners and hospitals. I think that's a really important thing for people to keep in mind, that this is an opportunity for collaboration. So moving on, you described your assessment as a grassroots or trickle-up process as opposed to trickle-down. So what do you mean by this, and why did you choose to do it this way?
It's an excellent question. Basically, again, I don't mean this as a pejorative comment, but in communities throughout the United States, hospitals fall into two kinds of groups. One group, the hospitals actually followed the letter and spirit of the law, consulted the community that they live in through a whole series of processes, one of which is what Amy has so beautifully illustrated to you. Look at the secondary data sets, distill them down, and explain what the community health needs are by looking at these data sets. But again, given the specific requirements of the law, there is also a need to actually ask the people. What a concept. It's something that public health people have a tendency very often to do, and some hospitals have done it superbly. And again, I just want to emphasize, I have to give a lot of credit to two groups. One is the CEO and president of our hospital, Kathy Clark. She and I chaired the local CHMA process, and she has been most responsive to the community's needs. And we had a lot of help from our SHPDA, a statewide health planning organization in Honolulu. And we basically actually consulted the people. What many of the hospitals in Oahu and Honolulu did is they did a key informant survey, and they did consulting by the telephone and the internet. The people at maximal risk of the leading causes of death nowadays, the chronic diseases and their behavioral risk factors that Amy has again illustrated for us, don't always do the internet. I mean, heck, if they're sitting on a beach and have very little medical care, I'm not sure they all have laptops. And again, the key informant surveys get to the big dogs in the community, which is necessary. And that's the second group we consulted. I am again humbled by not only the CEO and president of our hospital, but our mayor, our chancellor of our university, superintendent of schools. The whole CHNA, the way it was intended, is based on the premise that the people know and that we are servants of the people. And again, our group has done that very well, and that is why ours is grassroots. And many jurisdictions across the United States are doing a top-down, grass-tops process.
Fantastic. Thank you so much for that. So the next slide, you shared this model, which I think is really interesting. So we'd just love for you to talk a little bit more about the model and how you used it to frame your work.
Thank you. It's, you know, it's funny. Each of you have seen, each of you on the webinar have seen some variant of this model. Frankly, Kate had an absolutely glorious one a little earlier, where she showed you the same thing essentially. So, you know, basically it looks like Kate, Amy, and I are using the military method of instruction. Kate is going to tell you guys what we're going to tell you. Then Amy told you some of the stuff from data, and I'm going to tell you what they told you. So go back, and if you look at Kate's model, that basically described why the entire county health rankings were set up, the rationale for having set them up, the whole reason and how they were set up, if you see. And this is another way of looking at the same thing. If you look towards the right, the downstream, and I have a more complicated one, but we thought we'd keep it a little simpler. I have one that if Kate wishes, I can send to her, and she can send to people who ask you that. Basically, for each of these categories, mortality, disease, injury, risk factors, to the right and to the left, there are data sources. So you can again estimate these very well. The big indicators downstream are infant mortality, life expectancy. Leading causes of death nowadays are all chronic diseases, slowly shifting to the left. The behavioral antecedents or precursors to them are something you all know. Tobacco use, violence, physical inactivity, nutrition, chronic stress. The part that, again, both Kate and Amy emphasized, and that's the part I want to stress very strongly, are the ones towards the left, the upstream issues that contribute to the genesis. They're the root causes of diseases. There have been many learned papers and many more user-friendly pieces put out about this. Basically, these diseases, many of them are caused by social inequities, issues of institutional power, and discriminatory beliefs based on national origin, sexual orientation, race, class, gender. And again, there's nothing in this that's counterintuitive and that many of you don't know. But if you take this in concert with the one that Kate showed earlier, it will show you why we are doing community health needs assessment. The end diseases and indicators are actually due to a lot of upstream causes which need to be changed, which is why the county health rankings very thoughtfully has metrics for all these downstream as well as upstream indicators. That's the short answer. I'm given to rambling a little bit, so I assure the ladies I'll try to be mercifully brief.
Well, thank you for that. And also thank you for making me sound incredibly brilliant by referring to the rankings model as my model. I wish that I could take credit for that. But I think this is another great illustration of some of the same concepts. And I know that different models speak to different people, so I think this is a mix of getting to see this visually in different ways. So moving on, the next couple of slides, you really talk about community benefit and community building. So maybe just tell us a little bit more about that and what your process is leading, how your process is leading towards that.
I'm glad Kate, just to go back to her comment, I called it Kate's model because she's sort of said it to you. If you guys,
I know, I appreciate that.
But those of you who have a more, want to look at the root causes of that model, Google two names, Bill Foege and Mike McGinnis. They had a series of papers in the 90s that resulted in that user-friendly model. So again, as far as I'm concerned, I'm going to just call it the Kate model and the County Health Rankings model. All right, community benefit. I'm going to keep this very simple. Let's say I'm a hospital and I have to meet the CHNA requirements. So the conventional Internal Revenue Service definition of community benefit was that I give, if a poor chap comes to me, I give them care, and the cost of that care I deduct essentially what in the bulletin says is charity care, or the amount when those who I give who are on Medicaid, it doesn't meet my costs. I deduct the difference between what it cost me and what Medicaid or Medicare compensates. That's the conventional definition of community benefit definition. And again, that's an easy definition. Again, those of you who want to get the root cause of this, go to the Schedule 990 of the Internal Revenue, in Google it, Internal Revenue Service, and look under H1. H is in Harry 1, and that'll tell you what the community benefit is. Next, please. If you look at the next one, which is the community building, this is, if you go to the upstream issues 3 slides ago, both in mine as well as in the Kate County Health Rankings and Roadmaps models, the upstream issues are what is community building. So basically this whole thing is based on the premise that we are not going to get the kind of changes we desire in the morbidity, mortality picture in these United States. Remember, we spend 18% of our gross national product on healthcare, and we rank below 17 in many of these indices compared to most of the major Western nations, and that's appalling. So the whole issue of why the county health rankings and roadmaps has all those upstream indicators, as does Amy with her chna.org, is these are the things. It's based on the very well proven scientific premise that health statistics, morbidity, mortality statistics, occurrence, genesis, and progression of disease is determined as much by circumstances outside the healthcare system. And again, Kate had another map on that. It showed schools, communities, work sites. Those are all things that this community building under IRS 990 H2, Harry 2, requires. And that is all it is. They're asking people, asking hospitals to look to see where they can actually help the community reduce the genesis and progression of disease in their community by looking at upstream issues, things like diabetes screening. Next, please, ma'am.
All right, so maybe you can tell us a little bit about the communities that you have listed on this slide and what you mean by that. I think your quote there is perfect and it very much sums up what the county health rankings are about.
Unmuted.
Again, since Kate didn't want to take credit for my giving her that, I need to hasten to add that Jim Marks and the Robert O. Johnson Foundation Group and some very progressive people in the Federal Reserve in Region 9 actually created that very attractive soundbite. Your zip code is a better predictor of disease than your genetic code. And that is not just a convenient aside. It is regrettably true. And again, if you look at multiple data sources, Amy has an absolute slew of them, as do the county health ranking roadmaps people. If you look to see two neighborhoods side by side, and I've seen a whole bunch of them, some in Washington, D.C., some in L.A., and a whole bunch here on my island. Honolulu and Anahola are two areas which are relatively low-income populations. So if you look at those zip codes versus where the tourists hang out, in which Poipo or Princeville, which are high-income neighborhoods, high-education neighborhoods, zip codes, you'll find that the zip code is a much better predictor, believe it or not, than the genetic code. And I think that's all. The reason the county health rankings and roadmaps are important is place matters, where some of these parameters have to be looked at in small geographic areas. Next, please.
And I just want to point out, I think that's such an important point that you're making, is that the county health rankings gives you information on the county level, and we're asking you today to talk a little bit about your primary data collection, because even within a county, we know that there are disparities between neighborhoods, communities, zip codes within that county. And so bringing that point up that these different cities within your jurisdiction really look very different, I think other people can really relate to that and realize that this is really where this primary data collection becomes essential. So we're going to move into talking a little bit more about that in detail. So So asset mapping was a key component of your assessment. So if you just want to tell us about that process, how you did it, why it was important, what it told you, that'd be great.
Thank you, Kate. It's a key question. In fact, I was going to focus on the secondary data sets, and Kate very rightly said, people know how to mine those data sets. What the heck did you get that was de novo data? And it's a very important point. You can go to the county health rankings to get many of the secondary data sources that you're going to look at. But this piece, both the assets map as well as the focus groups we did, has to be something, it's a seat of the pants, local effort you have to do yourself. And again, I want to give a lot of credit to the political, public, private sector leadership on this island. They were instrumental in doing all of this, and I was merely a facilitator for all these great people to do this. On the assets map, it's really simple. The two big things that Kate wanted me to talk about are the two major areas that we had primary data. One was the assets map, which is basically just an inventory. All it is you look to see, again, if you go back to that slide of Kate's that looks at community, education, county, work site, you look to see where are the major areas you have assets in the community. People usually look at the healthcare delivery system, and that's fine. Obviously, that's an easy one. But to look at assets for health outcomes, you need to also thoughtfully look at government, education. Education, you have to look at higher education, as well as colleges, as well as schools. Look to see what local research other people have done. Look at social services and other community indicators. These are key things to look at. And that's why CHNA is such an important thing, and you have the need for local communities to go out and look at these things. Next, please. And again, in the interest of time, what we did was we just took one area, healthcare delivery system, to show you how complex just one little piece is. And we have this huge book created, and believe it or not, it should be there, but it wasn't there before. We looked at everybody on this little island who does preventive care. We looked at everybody who does primary care, acute specialty care, mental health, rehabilitative services, continuing care, complementary alternative medicine, insurers. This is the healthcare ohana or family on this island. And they all have silos between them. So by creating a book, both a website-based book as well as a hard copy, and again, our SHPDA and our local health planning council helped us enormously. If you do this by yourself, all these are going to be tough tasks. But if you go to the community at large, recruit them, it's easy enough. And just like we did the healthcare delivery system, we looked at the education system and have the schools, colleges, indicators, some of which that Amy has shown you in gory detail. And all of this we have as an overall inventory of what we have for our assets. That's the assets for this island.
Great, thank you. And I think that's so important to make sure that we're looking. I think sometimes we tend to really want to look at the deficits and where the challenges are, but really spending some time focusing on what you do have and what you can build on and what's going well is a really important piece of assessment. So let's also talk a little bit about the focus groups that you did with the community and why you chose to do focus groups, who was included, and how you recruited those participants, and how you decided to ask the questions that you asked that the participants can see here on the screen.
Thank you. Excellent question. And basically, this was the major primary data piece. And I absolutely have to give credit to two ladies, one who's our consultant in this area, Naomi Sugihara, and the other is our Director of Nursing, Tony Torres. Basically, what we did is our entire group, our core group, sat down and said, listen, we have all the secondary data stuff that Amy's given us. We have all the inventory of resources in this community. Let's ask the real people, not the big dogs. Every segment of this community, the people in the education system, the people in multiple work sites, the people in the places of worship, the Hongwanjis, the churches, and all those are the groups we looked at. How do we come up with the questions? This is fascinating, and believe it or not, this is not going to be a problem just in Kauai. It's going to be a problem nationwide. The people at maximal risk of both these chronic diseases as well as their behavioral precursors don't necessarily understand people like you and me, because these behaviors and diseases relate inversely to education, income, social class, and being white. So you have to have questions that they can understand and have people like Naomi and Tony who know how to ask it. So in the process, we had 15 sites where we did this. And the first thing is we kept me out of it, because the problem with getting the head of the hospital and myself, we might be an intrusive presence in the focus group. So what does good health mean to you was a very logical question. Tell me in your words. And some of that was put into language they can understand. We paraphrase what I speak the way I am. I'm an old Indian who's nearly 70. They paraphrase it in ways using a combination of local parlance, pidgin, and just did a gorgeous job. If I tell you the 200 people they talked to over the last 3 months, and the glorious amount of primary data, qualitative data we're wading through. They asked them, what are the strengths or good things do we have in our community? Then you turn around and say, hey, what would you change? What are your vision ideas or image for a healthy Kauai? See if upstream issues are on their radar screen. If so, what do they want done? If not, why not? See if the the upstream issues like an island having an invasion from the McDonald's and the Burger Kings and the Pizza Huts of the world. So all of those things ask real people. What would you like us to be like in health in 10 years? Let them know that ours is going to be the first generation where our children might have a shorter lifespan than us. Why? And what is important to them to have in our community to help enjoy a healthy Kauai. So it's a romantic but necessary view of health that the people know, and those of us in government and in the private sector who serve them are servants of those people.
Okay, great, thank you. So I think we are nearly to the end of our webinar time, so not much time for questions, but we do have one, Dr. Ball, that in the beginning of this webinar we talked about the CHNA is a great opportunity to open partnerships up between hospitals and other community partners. One particular community seems to be struggling with really getting that partnership started in an authentic way. Do you have any tips for really building a good partnership with the hospital using the community benefits, the CHNA, as a starting point or catalyst?
Excellent question, ma'am. I mean, the whole issue to me is, again, the public health mantra. Try to do things with incentives before disincentives come up. In other words, reach out to them. The hospitals, God bless them, many of them have the best intentions, but they're not used to talking to the community in the way that Obamacare wants and would like. So tell them walk them through the county health rankings and roadmaps. Walk them through the chna.org. And what they're doing instead is, instead of sitting in webinars like this and actually understanding what it needs to be done, they're going with commercial outfits on the mainland who are making a lot of money, who are giving them the same stuff you have in the county health rankings and roadmaps and chna.org in the public sector. And it's available in the public domain. So explain. Now, if it doesn't work, I'm a incentive-based guy, and God bless our present CEO of our hospital. But sometimes the health department, if they're just absolutely blown away just blown off by the hospitals, they have to tell them, I say, listen, the law requires that health departments be consulted. It needs to say the law requires that the people outside of the hospital need to be consulted. And if not, you're basically in violation of an IRS H1, H2 requirement. I hope it never comes to that. I hope we can do this in a way where people do it for positive reasons, not because of the disincentives that IRS might put your way if you're in violation. That's the short answer, ma'am.
Great, thanks. And I know that that is a difficult question and a difficult thing to do. That relationship building is time-consuming and a difficult process. So I think we are actually just about out of time, so we'll wrap things up here. So thanks to the support of the Robert Wood Johnson Foundation, we have 3 community coaches in the County Health Rankings and Roadmaps program, and our assistance is available at no cost to you. So please don't hesitate to contact us if you need assistance with a tool, have a question, are wondering about a next step or a first step in your process. We are here to help. This is the first in our 2013 series of Take Action webinars. We're hosting 2 webinars each month, May through September, focused on each step in the Take Action cycle. The first will introduce you to the action step, and the second will be a smaller, more in-depth and interactive learning discussion of that particular action step. As always, we invite you to stay connected with us. We have a county-by-county blog on countyhealthrankings.org. You can follow us on Twitter, like us on Facebook, subscribe to our e-newsletter, lots of different ways depending on your comfort level and interest in technology. And finally, I think we'll end with this great quote: "You cannot feed the hungry" on statistics. It's that getting down and really talking to people that you're really going to learn a lot of great information from your communities. I want to thank Dr. Ball and Amy for joining us today and sharing some really fantastic information. If you have questions, let us know. We can pass them on and get some answers for you. And again, join us on May 28th for a more in-depth exploration of chna.org and some of the assessment tools from the County Health Rankings and Roadmaps Action Center. We'd love to chat with you more later, and join us for the rest of the webinars this year. Thanks so much, and have a fantastic day.